Hello, my name is Eric Lowe, and I'm an NIH T32 Gastroenterology Research Fellow at the University of California, San Diego. On behalf of my co-authors, Dr. Aus Hassan, Dr. Abbas Femi, and Dr. Raina Al-Dapadi, I'm excited to share with you the key findings of our article, Evolution and Evidence-Based Adaptations and Techniques for Peroral Endoscopic Myotomy for Achalasia, as well as to discuss how POEM can continue to evolve, highlighting opportunities for future research. I'd also like to thank the GIE for providing us the opportunity to share our findings and thoughts regarding the evolution of POEM. We thought it was important to publish this article, which highlights the evolution and evidence-based adaptations and techniques for POEM as the incidence and prevalence of achalasia has been increasing, and POEM has become standard practice at many GI centers throughout the US. To recap, achalasia is the most well-characterized esophageal motility disorder. This is in large part due to the evolving diagnostic and physiologic research that have been developed over the past 2 decades. Now with the Chicago classifications in its 4th iteration, 3 distinct subtypes of achalasia have been characterized using high-resolution impedance manometry. The identification of achalasia subtypes has led to improved clinical outcomes as treatment recommendations vary among these subtypes. Currently, surgical Heller myotomy, pneumatic dilation, and POEM are all first-line therapies for type 1 and type 2 achalasia. However, POEM is the first-line therapy recommendation for type 3 achalasia. Since the inception of POEM in 2008, the technique has remained relatively unchanged. Efforts have focused on improving clinical outcomes, reducing rates of post-POEM GERD, and limiting overall procedure time through adaptations and procedure techniques such as myotomy thickness and length. We have detailed these adaptations in our review article, but I'll cover the key takeaway points in this video, as well as highlight future areas of research interest. Regarding the evolution of myotomy thickness, the initial POEM technique called for selective myotomy of the circular muscle layer. However, since then, studies have shown that full thickness myotomy compared to selective myotomy resulted in shortened procedure time and similar treatment efficacy without compromising more adverse effects such as post-POEM GERD. So to date, the recommendation for POEM myotomy thickness is for full thickness myotomy across all subtypes. An interesting research opportunity revolves around real-time physiologic testing to help target a successful or optimal myotomy. Using endoflip and distensibility indices of the lower esophageal sphincter may help guide intraoperative POEM in myotomy technique in the near future. Regarding the evolution of myotomy length, the initial POEM technique described a mean esophageal myotomy length of around 6 centimeters and a stomach myotomy length of 2 centimeters, similar to surgical Heller myotomy lengths. However, since then, randomized studies have demonstrated that shorter esophageal myotomy length, defined as less than 3 centimeters on the esophageal side, is non-inferior to the standard esophageal myotomy lengths in terms of efficacy. It also significantly decreased procedure time, in one study showing an average procedure time of 44 versus 72 minutes. In addition to length of esophageal myotomy, the length of gastric myotomy has also been studied. Clinical efficacy has been shown to be similar between those who had a shorter gastric myotomy, around 2 centimeters, compared to those with a longer, greater than 3 centimeter gastric myotomy. Additionally, a double scope technique allows for more accurate length assessment of myotomy on the gastric side and may be particularly useful in patients with difficult to identify gastroesophageal junction or altered anatomy. So to date, the recommendation for POEM myotomy length for achalasia subtypes 1 and 2 favors a standard short esophageal myotomy of less than 3 centimeters with a 2 centimeter extension into the gastric side. It is important to note that these lengths are estimates. Currently, there's no established method to calculate the myotomy length due to several factors, including resistance on the scope in the submucosal tunnel. As the measurements of the scope can change dramatically, we should develop ways to optimize measurement of myotomy length. Myotomy length for type 3 achalasia differs from type 1 and type 2 achalasia. The characteristic esophageal body spasticity in type 3 achalasia can be targeted with proximal extension of the myotomy along the esophageal body. In comparative studies, this tailored extended myotomy approach has been shown to be more efficacious compared to a non-tailored myotomy during POEM or during surgical Heller myotomy. Therefore, POEM is now the first-line therapy for type 3 achalasia. The optimal modality for determining length of myotomy has not been established, but it's typically been based on high-resolution manometry. Another research opportunity is determining the optimal strategy for determining myotomy length, as well as determining if or how endoflip and endoscopic ultrasound can contribute to this decision. A criticism of POEM compared to other therapies of achalasia is the rates of post-POEM reflux disease, or GERD, which may be documented in 9 to as high as 47% of patients, depending on the diagnostic method. Techniques to reduce post-procedure GERD have been characterized, including shorter gastric myotomy and avoidance of sling or oblique muscle fibers. However, more studies are needed to identify patient-specific risk factors for post-POEM GERD, such as BMI or pre-POEM lower esophageal sphincter distensibility, which may help characterize a high-risk group. In summary, POEM technique has evolved since its inception in 2008. Based on the current literature, it is recommended to perform full-thickness myotomy regardless of the subtype of achalasia. A short 3 to 4 centimeter esophageal myotomy with 2 centimeter extension into the gastric side is the recommended length for myotomy for type 1 and type 2 achalasia, whereas a tailored esophageal myotomy based on spastic segment length with 2 centimeter extension into the gastric side is recommended for type 3 achalasia. As the procedure technique becomes more widely practiced, efforts should focus on promoting multidisciplinary and individualized patient care for individuals with achalasia. For instance, patients with type 3 achalasia should be offered POEM with an extended proximal myotomy, as is reflected in the societal guidelines from the ASGE and the ACG. Additionally, all patients should be counseled on their risks of adverse effects, including post-procedure GERD, as well as considerations such as time off work, length of hospital stay, and potential for reintervention. Thank you for listening.